So changing a little pace here, we're going to go to the interstitial lung diseases. These are a little bit different diseases than obstructive diseases, than the obstructive diseases that we just talked about. So interstitial lung diseases, with all these diseases, they have a couple of common denominators, and we're going to talk about that. They have a lot of similarities. So if you remember just the similarities, then you could remember the specific diseases. There are some differences with the specific diseases, but they share a lot of common material here. So all these diseases, there's chronic inflammation. So something triggers a chronic inflammatory process in the lungs, usually at the level of the interstitium. The interstitium is the lining around the alveoli and at the alveolar level. So for example, in people that have asbestos exposure, it's the asbestos fiber that they breathe down, and this triggers an inflammatory response. And then what happens with chronic inflammation, because this continues, it's chronic inflammation, there's eventually fibrosis of the interstitium. And then when this happens, when there's fibrosis around that area, gas exchange is disrupted, and these patients become hypoxemic. They all share similar clinical symptoms. The number one reason they come to the physician is chronic exertional dyspnea. So this patient says, I get short of breath when I walk, doctor. And then you say, like, well, how long has this been going on for? He said, well, it's the last month or so that this got worse, but I actually have it for at least 2-3 years. And that's the chronic, and it works up. First it's mild, and then eventually the last couple of months before they come to the physician, they tell you, I walk across the street and I get short of breath. On the exam, you may find fine crackles, especially in some diseases like idiopathic pulmonary fibrosis. At the bases, it's common to see things like that. And then some other stuff that are related to the chronic lung disease, the clubbing. You may see clubbing in their fingers, and you may have evidence of cor pulmonale, right-sided heart failure, if the pulmonary disease has been extensive. And so all these things, all the interstitial lung diseases share this. They have the same presentation. There is no difference, and there's really no way to tell the difference just on presentation. They also share common X-ray findings. So, for example, they all have a reticular pattern, and some of them show this thing called a ground glass appearance. This occurs with chronic inflammation. This ground glass appears. And then they have similar pulmonary function tests. So all of these show intrapulmonary restrictive disease and then a decreased DLCO. When I say intrapulmonary restrictive disease, I'm sorry, I should say the intrapulmonary restrictive disease. Along with that is a decreased DLCO. That's what makes intrapulmonary restrictive disease, because if you just have a restrictive disease on the pulmonary function test, you can't tell the difference between extrapulmonary restriction, remember the kyphoscoliosis, the morbid obesity, versus intrapulmonary restriction like idiopathic pulmonary fibrosis, like sarcoidosis, like pneumoconiosis and so forth. The only thing that tells you the difference between one and the other is the decreased DLCO, which you only find in interstitial lung diseases in the intrapulmonary restriction. So intrapulmonary restrictive lung disease, along with that, the DLCO is part of that. So the workup is similar. After you do the initial chest x-ray, you do a high-resolution CAT scan to see what part of the lung is mostly affected, to know what to look for. And then the most appropriate step always in the end of these diseases to confirm the diagnosis, sometimes just to exclude other diseases, because some of these diseases don't have a pathognomonic finding, but they have certain findings that look a certain way, and then you exclude certain other diseases, and then you say this is the likely diagnosis. So always in these cases, we start off with the x-rays. We may do pulmonary function tests to see restrictive disease, or we may get the pulmonary function test because we're thinking something else, like a COPD, and then we find intrapulmonary restriction. That's similar to all these diseases, and then the workup is similar. After all this, it's after you do the chest x-ray, you do a high-resolution CAT scan, and a biopsy to confirm or exclude the diagnosis. Now look at this. This is all the interstitial lung diseases. There's over 100. Some people say it's probably over 200 diseases, and there's a lot of them here, and we're only going to cover certain of them, but basically just to give you an idea, when you see intrapulmonary restriction and, you know, a ground glass appears on the x-ray, there's a lot of diseases you need to cover. That's why you do the high-resolution CAT scan and the biopsy. So some of them, idiopathic pulmonary fibrosis, sarcoidosis, the occupational lung disease, a big category here. That's why they say, what is one of the most important things that we get in patients with interstitial lung disease? The answer is you get a good history, occupational history. You make sure they weren't exposed to something you should be looking for. Silicosis, asbestosis, and all that stuff. And then there's the autoimmune diseases like lupus, like Wegener's disease, sometimes rheumatoid arthritis, and so forth. And then there's some weird diseases like eosinophilic pneumonia and Sturge-Strauss syndrome and so forth. All these, along with another, 90 of them, are part of the interstitial lung disease continuum. Let's do this case, and then I'll tell you the diagnosis a little bit, and then we'll go back and ask some questions about it. A 55-year-old man came to me for the evaluation of dyspnea with exertion over about 6 months. He says that recently walking across the room has become difficult. He has no significant past medical history. His respiratory rate is 24. His pulse is 106. His physical exam shows a positive increased jugular venous distension, so he's got right-sided heart failure right away. You find lung exam that shows fine crackles on inspiration, positive clubbing, and a positive trace edema. So when I first heard about the JVD on this guy, I said, well, he's got heart failure for some reason, but he had no hypertension, no hyperlipidemia in the past. And then on exam, we find the fine crackles, the clubbing, which shows chronic lung disease, the trace edema that goes along with cor pulmonale, and then I do the chest x-ray, and look, I find this diffuse reticular nodular pattern in pretty much a normal heart size. So this guy has some form of interstitial lung disease. Now the question is what? And what this guy had is this thing called idiopathic pulmonary fibrosis. It's a chronic lung inflammation. It occurs out of the blue with no precipitating factor. It's of unknown etiology. And the interesting thing about this disease is it has no other systemic manifestations. What I mean by that is it doesn't involve other organs. It only involves the lung. It usually occurs about the 5th decade of life, and the typical presentation with the interstitial lung disease will dyspnea on exertion, fine crackles on the exam, maybe clubbing, maybe edema and JVD because of the cor pulmonale, and the ground glass appearance on the x-rays usually involving the lower lungs. The bronchoscopy and lavage are nonspecific, but they include the other disease. For example, this guy, we just found inflammation. Nothing much, but it excluded other diseases like pneumoconiosis, like sarcoidosis, like autoimmune diseases. The treatment for this disease, then I put a question mark here, are steroids, because only about a 1/5 of these cases really respond to steroids. The rest don't. And we have to think about some other things to do in these patients. So some of the immune agents have been used, like azathioprine, cyclophosphamide, 6-MP, and so forth in these patients. And a lot of patients are looking, a lot of physicians are looking at these patients now to try to do a lung transplant or a heart-lung transplant. That's the definitive treatment in these patients. So a progressive chronic lung disease, idiopathic pulmonary fibrosis, the triggering event that causes all the inflammation, we don't know why these people get it, but we don't know the etiology, but it goes on for a long time, it's relentless, and the treatment is questionable with the steroids, but that's where we start off with. So going back to this case, I'm going to ask a question or two. A 55-year-old man that comes in with dyspnea on exertion for over 6 months, he says that recently walking across the room has been difficulty. He has no significant past medical history. His respiratory rate is 24 and his pulse is 106. It's the same case. And now we find that he's got JVD and so forth, the clubbing, the crackles on inspiration, and the reticular nodular pattern on the x-ray. The bronchoscopy and lavage show no granulomas, chronic inflammation with increased macrophages. That's the typical thing that we find in IPF, idiopathic pulmonary fibrosis, chronic inflammation, nonspecific, with increased macrophages. This is not pathognomonic for anything, but look, I've ruled out other stuff. No granulomas, right? So no sarcoid, nothing else there. I ruled out, pneumoconiosis because I didn't find any fibers there consistent with pneumoconiosis. And there's a lot of other things. I didn't find eosinophils there that would point to eosinophilic pneumonia and so forth. So I'll make the diagnosis because I've excluded all the other stuff and because this person fits the pattern of idiopathic pulmonary fibrosis. Now here's the question. You have made the diagnosis of IPF in the previous patient based on the bronchoscopy result, excluding other diseases. After discussion with the patient and his family, you have decided to start oral prednisone at 60 milligrams daily and make an appointment to see him after 3 months. What is the best follow-up test for response to treatment? So they say, when he comes in 3 months, you're going to ask him, sir, are you short of breath again? Do you have dyspnea in the air? The patient's going to say, yeah, I do. Have you seen any difference from, the last time? He may say yes, he may say no, but you want a more objective way to measure this. You put somebody on prednisone, they may feel better because, the prednisone makes them feel better 3 months later. That doesn't mean that though this made their, improved their disease in the lung. So the most important test is to find an objective way to measure lung function in this patient. So the right answer here would be to follow up lung function in this patient. I would do a pulmonary function test. And I would compare my FEV1 now to the FEV1 I had before, something like that, or the total lung capacity and all the volumes to the volumes I had before to see if there's any benefit. So if I went 1 year later and I had this patient on prednisone and there is no benefit, because I objectively measured pulmonary function tests, then I would say he fits into the 80% of patients. And since there's no benefit, I know in 80% of patients, I'm going to stop the prednisone. Versus, if I see an improvement of FEV1, if I see an improvement of lung capacities, then I'm going to continue the prednisone. So that's the way we manage these patients with the pulmonary function test to see if they really are doing well with the